the last section of this lecture, we're going to discuss more applied pulmonary physiology, specific cases that bring out relevant physiologic principles. Next section, we're going to talk about a couple other pathological conditions to which we can apply the pathophysiology principles that we learned earlier. One example of this is pulmonary embolism, a very common medical problem. In pulmonary embolism, a clot from the venous circulation, usually in the legs, dislodges, floats up, and wedges in the next capillary bed it sees in the pulmonary circulation. This can be fatal in up to 5%. Typically, the patients will present hypoxemia, chest pain, usually sudden onset, tachycardia, and tachypnea. The predisposing factors for this are summarized by Virchow's triad of venous stasis, endothelial injury, and a hypercoagulable state. Usually, test questions will allude to one of these predisposing conditions. For example, the patient will be in the hospital where they might be experiencing stasis. They might be recovering from an orthopedic surgery. They've had a recent endothelial injury as a result of this. Or they could have cancer being a relative hypercoagulable state. LV is a 65-year-old patient with breast cancer. She experiences chest pain, drives to the emergency room, and is diagnosed with pulmonary embolism. Which of the following would we expect? Let's go through these questions answer by answer. Would we expect her FEV1 to be less than 40% predicted? There's nothing about the pulmonary embolism that changed her lung volumes or her spirometry, so A is incorrect. Would we expect her PCO2 to increase to 90? Pulmonary embolism will cause dead space, which could raise her PCO2, but such a large increase in her PCO2 is unlikely, given that she's going to compensate this by breathing more rapidly and deeper. Would we expect her PaO2 to go down to 55? It's certainly possible that her PaO2 could go down as a result of the VQ imbalance from the pulmonary embolism. So C is probably the correct answer. D, a pH of 7.05, is unlikely. It's possible that a pulmonary embolism can cause circulatory collapse, can cause shock, hypoperfusion of peripheral tissues, and lactic acidosis. But in this patient that drove herself to the emergency room, I wouldn't expect her to be in shock. The correct answer here is C, hypoxemia with a PaO2 of 55. This is a useful diagnostic test for pulmonary embolism. All of the following occur in a patient with pulmonary embolism, except, once again, going through each one. Increased dead space. We know that a pulmonary embolism causes increased dead space. A is not correct. Increase in pulmonary vascular resistance. Pulmonary embolism does cause an increase in pulmonary vascular resistance, and it does this because it redirects blood flow from going through the entire pulmonary circulation to going through the pulmonary circulation that's just not occluded by that clot. The same amount of blood is going through less pulmonary circulation, therefore the pulmonary vascular resistance increases. Pulmonary embolism does not cause shunt, so C is the correct answer. D, we would expect pulmonary embolism to cause a decrease in diffusion capacity because it's decreasing the surface area for gas exchange. And we would expect pulmonary embolism to cause an increase in the VQ mismatching. That's how pulmonary embolism causes hypoxia. Once again, the correct answer is C. Atelectasis refers to airways and everything distal to the airway that's atelectatic, including the alveoli, collapsing. It'll typically happen when a patient is not taking very deep breaths. For example, after a major surgery or because something's obstructing those airways, if a foreign body, a tumor, or a mucus plug is blocking them off. Atelectasis often will cause hypoxia. The atelectasis is shown on this CT scan with the area of collapsed lung in the right posterior lower lung distal to what's likely an airway obstructing mass. BW is a 46-year-old man that underwent a cholecystectomy, had his gallbladder taken out. On post-op day 2, he gets a low-grade fever and decrease in his arterial oxygen content. A chest x-ray confirms atelectasis. He's put on 100% oxygen, but only has minimal improvement in his PaO2. goes from 60 to 75. Which of the following explains hypoxia in this setting? We know, because supplemental oxygen did not help totally correct his hypoxemia, that his hypoxia is due to shunt, and D is the correct answer. In the case of atelectasis, you've got that whole component of alveoli that are not ventilated, but they're still perfused. This is a classic example of shunt. The AA gradient is an important concept. The AA gradient represents the difference between the alveolar oxygen and the arterial oxygen. How much of a drop we see between alveolar and arterial tells you how much of a problem with gas exchange you're having. In general, a normal AA gradient is between 10 and 20, and it increases slightly as we get older. Anything that's above 30, I would say, is a good rule of thumb to remember is abnormal. If we see hypoxemia with a normal AA gradient, we think about respiratory failure from hypoventilation or a mechanical problem, as in the case of neuromuscular disease or obesity or kyphoscoliosis. Anything that causes an increased or abnormal AA gradient suggests that there's a barrier to effective gas exchange, and it can occur in a multitude of clinical settings. For example, atelectasis, VQ mismatch, in a pulmonary embolism, or in the case of shunt. In a hunting accident, you accidentally, of course, shoot a paralytic blow dart at the vice president, causing him to become completely paralyzed. Luckily, you've got a ventilator with you. You place him on the ventilator with settings of a tidal volume of 400, a respiratory rate of 12, and FiO2 of 21%. You do a blood gas, and it shows a PaO2 of 55 with a PaCO2 of 72. What's his AA gradient? We can do this by doing the alveolar gas equation. We're at sea level, where the barometric pressure is 760. We know that he's got normal water vapor, so the inspired oxygen is going to be 760 minus 47 times 21%. We need to subtract from this his PCO2 divided by 0.8. When we do this, we find that his AA gradient is 5. We get a alveolar oxygen of 60 compared to his arterial oxygen of 55. 5 is a normal AA gradient, so we know that our vice president doesn't have a problem with his lungs. The only problem is that he's hypoventilating and his PaCO2 is too high. The treatment for this patient would just be to turn up the respiratory rate on his ventilator and increase his alveolar ventilation. Another question with the same example, we can increase the PaO2 by doing all the following except. Obviously, increasing the FiO2 would help. A is not the correct answer. B, I'm going to leave for a second. C and D, both increasing the respiratory rate or increasing the tidal volume, would raise his minute volume and therefore lower his CO2. So these are incorrect. These are both would be expected to increase his PaO2. Answer E, which is a little bit tricky. If we added dopamine, it would improve his cardiac output. This would decrease his zone 1 lung, and therefore decrease the dead space in his lung and increase the surface area for gas exchange. This would increase his PaO2. The correct answer here, the maneuver that would not increase his PaO2, would be suctioning out his airways to decrease the atelectasis and resulting shunt. And the reason we know this wouldn't help is because we know the patient does not have shunt. They had a normal AA gradient. Shunt will always cause an increase in AA gradient. Shunt and VQ mismatch both. Correct answer here is B. This is a challenging question. Let's think about our physiologic response to exercise. When we exercise, we increase our O2 consumption. Our muscles are using more oxygen. We increase our CO2 production. Our muscles are producing more carbon dioxide. Directly related to how much CO2 production we have, we increase our ventilation exactly that much. These responses happen automatically. Let's look at these responses on the arterial blood. We should see no change in the PaO2, no change in the PaCO2, and generally no change in the pH. Sometimes if we're very vigorously exercising and we begin to anaerobically exercise, we'll see a decrease in the pH as we undergo lactic acidosis. This is sometimes referred to as crossing the anaerobic threshold and is only seen in very vigorous exercise. In the venous blood, we expect to have a higher mixed venous CO2, but this mixed venous CO2 will be compensated by increased ventilation. Pulmonary blood flow will go up as cardiac output goes up, but the ventilation perfusion will be more evenly distributed in the lungs, and we'd have less physiologic dead space as a result of that higher cardiac output. The oxygen hemoglobin dissociation curve, you could argue that it would shift to the right as we're producing more CO2, as we may be undergoing lactic acidosis, as our temperature is rising as our muscles are working. Just reviewing, O2 consumption increases, CO2 production increases, ventilatory rate obviously goes up, but we have no change in our arterial PO2 and PCO2, and generally no change in our pH, unless we're doing very strenuous exercise. Venous PCO2, however, would increase. Pulmonary blood flow and cardiac output both increase. Ventilation perfusion ratio is more evenly distributed with less dead space. And the oxygen hemoglobin dissociation curve potentially would shift to the right. Let's now look at our responses to high altitude. At high altitude, the atmospheric pressure is lower, and the alveolar PO2 therefore would be lower as well. The response to this is to increase our minute ventilation. We expect, because of lower alveolar O2, a lower arterial O2 as well. In response to this, we're going to breathe more rapidly. This will raise the pH in our blood and create a relative respiratory alkalosis. The relative hypoxia, because of altitude, will cause an increase in pulmonary resistance as we undergo pulmonary hypoxic vasoconstriction. This will cause an increase in pulmonary artery pressure, and over time will lead to hypertrophy of the right ventricle. The oxygen hemoglobin dissociation curve, you can make an argument of whether it would shift to the right or shift to the left. For the purpose of this slide, they make the argument that it shift to the right. But you could also make an argument that the increasing pH would shift the curve to the left. I think it's unrealistic for you to be tested on which way the oxygen hemoglobin dissociation curve would shift in the case of high altitude, because you can make an argument for it going either way. Reviewing once again, alveolar PO2 is going to decrease because of a decrease in atmospheric PO2. Because of this decrease in alveolar PO2, our arterial PO2 will go down as well. Ventilatory rate will go up in response to both hypoxemia and to the general stimuli of exercising at high altitude. Arterial pH will increase as we hyperventilate. Hemoglobin concentration will increase. Our red blood cells, our kidneys will cause our red blood cells to produce more hemoglobin. 2,3-DPG concentrations will increase. And as I mentioned, I think you could make an argument about the oxygen hemoglobin dissociation curve shifting either way. Pulmonary vascular resistance will increase, leading to higher pulmonary artery pressures. That concludes the section on applied pulmonary physiology. It also completes the lecture series for pulmonary physiology. Remember, when you're studying, you're not just studying for step 1 of the boards, you're studying to be able to take care of the patients that you're going to see as a physician. Good luck.